Hello, everyone. Welcome back to another episode of Forward Physio. I'm your host, Noah Mandel, and today I am joined by Taylor Goldberg, who I think when people who are maybe having a preconceived notion of a chiropractor would listen to this podcast and think I'm speaking to a bit of an enigma because Taylor works with people online and with people with hypermobility, which is really, really interesting. Taylor, would you mind giving us a background into who you are as a professional and what you do?
Yeah, absolutely. Hi, I'm Taylor. I'm a chiropractor by trade. I would say now at this point, I'm not the only enigma. There's a decent amount of us going online, which is really, really awesome to see. But when I first started, yes, definitely. But I call myself now a virtual hypermobility coach. I work specifically with hypermobility, so hypermobile Ehlers-Danlos syndrome, hypermobile spectrum disorder, or suspected either of those two. You do not need to have a diagnosis to work with us. And I only work with that population, and it's been truly the most fulfilling journey. I love my people, and I'm excited to talk today.
How did you get into that in the first place?
Yeah, so I have hypermobile Ehlers-Danlos syndrome, and I honestly never planned to go this route. I was the girl in school who didn't tell anybody that I had it because I didn't want to be that girl. And then my third year of chiro school, this was also right around COVID, I had a neck adjustment by a professor that took me over the edge and gave me some neuro symptoms that were really, really scary. And I realized for the first time, I can't keep ignoring this and I can't keep not talking about it. And so I actually posted about that on social media. And like I said, it was during COVID. So like TikTok was new and things were blowing up easier. And I went viral. That's the honest answer. And I realized for the first time, there's so many other people that need help with this condition. I had no idea. I genuinely had no idea how many other people were living with this. And that's when I started to be like, maybe this is something I can help people with. And my roommate at the time was my clinician in school. And we started practicing on myself and figuring out, okay, what helps, what doesn't help. And we just posted our journey and the rest was kind of history.
Cool. And I know like you dive into a lot of the literature as well. I'm guessing that probably happened after this whole event when sort of people started coming to you now and you said like, okay, I have to sort of become an expert in this stuff.
Yeah, I admittedly did not look at any EDS research prior to this because I was like, I don't want to help myself. I don't want to know about this stuff. And then unfortunately, when I started to want to go down that route, there was none. There was really limited research on this condition. And for the first time ever in literally 2025, we now have good research for the first time from the Norris lab on these conditions, which has been a game changer. And it's been truly 5 years in the making for that to happen. And we're entering the EDS Society I forget what they call it, but they're on a road to 2026 and there's a lot of funding going on in the EDS world for the first time. So big things are coming that way, which is great.
Very cool. Yeah, I think it's a very unrecognized condition for a lot of people. And I think when some people think about hypermobility, one of the first things they think of is like, oh, it's when people are like double jointed, right?
Yeah.
Which the more time I spend as a physio, the more confused I am about what a double joint is. But anyway.
Doesn't exist. So
Yeah.
Double jointed is a fake word. We do not have more than one joint. But if you have been told you're double jointed, what that really means is that you're hypermobile, aka your joint goes far past the end range it's supposed to go.
Got it. Okay. And is that the end of it? Is that purely what defines a hypermobility disorder? What are the different types of hypermobility?
Yeah. So there's a couple of characteristics. So a hypermobile joint, one joint that goes past its end range would be labeled a hypermobile joint. If you have 5 or more of those in your body, then you get labeled with generalized joint hypermobility. If you then think of that as the top of our pyramid, and then it's going to come down into 2 sections, symptomatic and asymptomatic. Asymptomatic hypermobility does exist. We'll talk more about the risk factors for asymptomatic becoming symptomatic. But when we go to the symptomatic side of things, that then splits off into 2 other categories, genetic and acquired. Genetic is your connective tissue disorders. This is Lloyd-Dietz syndrome, all of the Ehlers-Danlos syndromes, Marfan's. There's a bunch of connective tissue disorders. And then acquired is what you could get from a sport like gymnastics, dance, cheerleading, even a car accident like whiplash can give you generalized symptomatic acquired joint hypermobility, which is a mouthful. And so that's kind of the process.
Got it. So if someone has an injury to maybe their ligaments at one joint, that joint may become hypermobile. It may move excessively, but you wouldn't say like that person has generalized hypermobility. They
No,
just have it
that
in
would be
one joint.
localized. Yeah. So
Got
one
it.
joint is localized. If you have it only in your hands and your feet, that's peripheral. General is 5 or more. And then historical is the joint was hypermobile at one point, but no longer is.
Got it. The whole acquired hypermobility is pretty interesting to me. When people are, when you think about a dancer or a gymnast, a lot of the time I wonder, like, are these people just really good at their sport because they're hypermobile, or did they get it from the sport, or is it a little bit of both? Do you have an answer to that?
I would say it's both. I would definitely, I'll speak for myself here. I was a competitive cheerleader my whole life, and I definitely enjoyed the very first day I went to cheer camp. I knew it was my sport, and it was because I was hypermobile. I was a star. I was like, everybody was like, oh my God, she didn't even have to stretch and she could pull a needle. So I think there is that camp. But then I also have friends who were not hypermobile and now are because of cheer and because of their sport. So I do think it's a mix of both. I think most people who found the sport really easy or didn't have to stretch or didn't have to put in the same amount of effort as far as the body position piece goes, but then found it really hard to do the power piece of their sport, that usually to me means it's probably more on the genetic side. Whereas if you had to try harder to gain that range of motion, but not as hard to gain the power piece of your sport, it's probably more on the acquired side, but that's just my opinion. I wouldn't say that's like a fact.
Got it. Okay. So when it comes to people that have generalized hypermobility, and you mentioned there's asymptomatic and symptomatic, what are the symptoms that people are getting? Is it just pain, or is there more than that? Does it depend on what type of hypermobility condition that they have?
Yes. So let's stick in the symptomatic bucket and let's start with the genetic side. So if you have a genetic connective tissue disorder, connective tissue lines literally everything in your body. It lines your organs. It's what your ligaments are made out of. It's everywhere. And so this condition can affect every system in your body. And so the symptoms are going to be not just musculoskeletal in nature. They're going to be systemic. This is a systemic disorder. Some of the common musculoskeletal symptoms you're going to experience is chronic pain, as like chronic widespread pain, as well as subluxations or dislocations. And I'm talking true medical subluxations, not chiropractic subluxations, whatever those are. And then there is going to be some systemic that are going to be pretty general for this population, like fatigue, brain fog, anything in the autonomic nervous system family. GI system usually gets pretty affected by this condition. And then we're also seeing heightened endo, as well as things in the hormone camp are starting to become more and more clear that that's a part of this story as well.
Endometriosis?
Endometriosis.
Yeah.
Yep. And then we're also seeing a lot of mast cell, which is a cell that lives in your connective tissue. Symptoms come along with this condition. So there's something known as the triad in this world, and that is some form of an autonomic disorder. Usually the most common one you hear about is POTS. And then they say MCAS, but I like to make it simpler and just say your mast cells are angry, because to get an MCAS diagnosis is pretty much impossible at this point. And then HEDS would be the triad.
Why is it so hard to get a diagnosis?
There's no good testing. So the only way to really know if you have true mast cell activation syndrome is to get a biopsy, and you have to go under general anesthesia for that, which is very, very invasive and really not necessary when we're seeing if you treat it like it's MCAS and you get better, it's probably MCAS, and we don't need to put you under general anesthesia for that.
Yeah. So there's a lot of symptoms that can occur, but there's also a lot of hypermobility disorders. Like, how many types of Ehlers-Danlos are there?
I think now there's 14. There might be 15. It's changing like every day. There's at least 14 for sure. There might be 15.
And we obviously, I think we could spend a whole podcast going through each one of them. But in general, what are some differences between these different types?
Yeah. So we can kind of compartmentalize them. So the vascular type, VEDS, it's rare, but it is the most severe. And that one has a lot of big, bad, and scary, a lot of heart conditions and risk for stroke, a lot of things that you do not want. And VEDS is a progressive disorder, which is a very, very scary disorder to have to live with. All of the rest are not progressive disorders, and we can kind of pick them off of HEDS and then the rest.
Okay.
So HEDS is the most common type. It is not a progressive disorder. A progressive disorder is something like Alzheimer's, meaning it gets worse no matter what you do. HEDS is not that. There are ways that we can manage it. It might feel like it's getting worse, but by nature, the condition does not get worse on its own, which is great. And that should bring people hope. Sometimes it doesn't, but it should. And so in the HEDS world, we are now finding that it is 1 in 500 people are living with this condition, although we believe it's probably more than that. If you would have asked me 3 years ago, it was 1 in 5,000. And so the research is finally catching up, which is great. And HEDS is the only type that currently doesn't have a genetic marker, although the Norris lab is working really, really hard and they are doing great, great work to create biomarkers around this. But as of right now, it is still a clinical diagnosis and a diagnosis by exclusion. So you have to get all of the other EDS types, which do have genetic markers, ruled out before you get this condition ruled in.
Mm. So you have to get all these different genes tested, and
Yes.
the other 13 or 14 or so, those all have to not be apparent.
Exactly. As well as any other connective tissue disorder. So Marfan's, Loeys-Dietz syndrome, there's more, but those are the most common.
Okay. So you've mentioned the Norris lab a few times.
Yeah.
What is that?
Yeah, so they are in South Carolina. Yeah, they're in South Carolina. Courtney Jessimer, sorry if I pronounced her last name wrong, is the lead researcher there, and they are they're an EDS specific lab, and they are working on such amazing research for these conditions. Specifically, their biggest mission is to figure out what is the gene, if there is a gene for HEDS, and if not, what are going to be what they're labeling as subtypes. They just came out with a really, really cool paper that took 2,000 HEDS patients and did a really extensive survey. And that's the most amount of patients I've ever seen in an EDS study. So it was a really, really big deal in our world. And they found some things that we've been saying for a really, really long time. Number one, that asymptomatic joint hypermobility does exist, but there are risk factors to making it become symptomatic. And those risk factors are trauma, like physical trauma or emotional trauma, and then infections or viruses. And that's why we're seeing a huge spike right now with COVID. We're also seeing it with Epstein-Barr virus. So mono can also make asymptomatic turn into symptomatic. And then the third is postpartum or pregnancy. And so these are, when it comes to that conversation of asymptomatic hypermobility, it doesn't need to be something that we need to obsess or quote unquote worry about. But at this point in time, I do think it's good to just bring up to people that these are risk factors for you to become symptomatic. And if you encounter these risk factors, let's make sure that we have support so that we can ensure it doesn't become something it doesn't need to.
Right. And you don't want to lead people to have the expectation that if they're postpartum, they're going to develop these things.
Right.
But at least maybe they're aware of that, so that if new symptoms start to align with that period of time in their life, they could maybe have an idea of what they're dealing with and not have so many years of being misdiagnosed, right?
Exactly. And like in a perfect world, we could find a non-nocebic way to have that conversation so that, okay, if I get these symptoms, I know exactly where to go to, because what's happening right now is women are postpartum and they're getting these scary symptoms and they tell their doctor, and then their doctor's telling them it's all in their head, and then they're going on Google and there's a lot of not so good things on Google and Reddit around these conditions, and that now they think they're going to die. And it's like, it really is that dramatic online, and it's a big problem.
For sure. So you mentioned trauma, and it could be physical or emotional. When it comes to the physical trauma, that would be trauma that occurs sort of after they've already had hypermobility, right? It's not like what we said before, like an accident can lead to a hypermobile joint.
Right. So both could be true. So if you have generalized joint hypermobility, 5 or more, but you have no symptoms, you have no chronic pain, no subluxations, nothing, and then you were to get into a car accident or have some sort of traumatic event, you're at a higher predisposition to now become symptomatic.
Got it. And I'm no expert in this, but if anyone's confused by why that could be the case, I'm just thinking in my mind right now, like, again, this is a systemic thing.
Yeah.
And maybe systemic factors that occur after trauma can be related to that. So maybe there's some immune system mechanism.
That was going to be my next thing. Yes. So the paper actually did dive into that. And so there is for sure an immune component. We cannot say how or what, but the hypothesis is that there is a subsection of this condition that acts like an autoimmune disorder. And that's what the Norris lab paper kind of said we need to further dive into. They did not conclude on that, but it was very clear that that is where everybody in this field's head is really at. And I will say anecdotally, that's what I see very, very often is it acts like, it might not actually be an autoimmune disorder, but it certainly acts like one. But we're really starting to realize the mast cell component, which is an immune cell, is a really, really big driving force. And in my opinion, for the asymptomatic going to symptomatic, and I want to be clear, this is an opinion, this is not fact. In my opinion, the mast cells are the driving force for that.
Got it. And that it sort of aligns with a virus also being a risk factor as well. And just so that everyone remembers, your immune system is not just for viruses and infections, it's also for healing, which is why we brought up the trauma component.
Yes.
Right?
Yep, yeah. Exactly. And another common symptom with a connective tissue disorder is slower wound healing. And that makes sense why.
Interesting. So when people with asymptomatic HEDS develop symptoms, is that including all of the other symptoms we discussed before? And I know from person to person it will differ, but are we just talking pain, or are we talking all of these systemic issues that could arise, like with their GI system or with wound healing?
Yeah, so it's a spectrum disorder. So some people will be on this end of the spectrum, some people will be on this end of the spectrum. I would say the people who go from asymptomatic to symptomatic are more commonly going to experience autonomic disorder symptoms as far as systemic stuff goes, and the mast cell ones. Whereas I see the ones who were symptomatic from birth tend to deal more with musculoskeletal and a little bit less of the systemic ones because I think of that immune response. But to be honest, that's where they're kind of going with those buckets of categories in the HEDS world, because right now HEDS is kind of just like this really broad spectrum, and there's a lot of different tunnels that you can go down. What they're thinking is there's going to be like 3 different subsections of that overarching HEDS. One where it's very systemic in nature, acts like an autoimmune disorder. One where it's the hypermobility piece is the one that is the loudest symptom in the room. And then one where it is more on the abdominal compression syndrome side, vascular, those types of syndrome side.
Got it. Okay. Can we dive into that last part there?
Yeah.
The abdominal and vascular symptoms.
Yeah.
People can have sort of some scary, funky symptoms sometimes when it comes to this, right?
Yeah. So there's, like I said, it's a spectrum. So I want nothing I say I want to be taken as fearful, but there are some big, bad, and scary things that can come along with these conditions because, like I said, connective tissue lines everything in your body. And there is a couple of vascular disorders that I do commonly see. The first would be abdominal compression syndromes. And so this is MALS, small SMAS. I can't pronounce any of the big words, so don't ask me to. And nutcracker syndrome. And then anything in the pelvic congestion syndrome family as well would be here. And the biggest thing with these ones that I would like all, especially muscular clinicians, to know is that if your patient or client is saying, when I eat, it hurts right after, that is a red flag that we need to get further testing. The amount of young women who have been told they had an eating disorder when they really had an abdominal compression syndrome is more than I would like to admit at this point in my career. And I think a lot of doctors write women off, especially in the dance world, in the cheer world, and in the gymnastics world. And don't get me wrong, eating disorders are also a huge problem in those spaces as well. But let's ask some deeper questions and not just write people off right away, because it might actually be that food just really hurts them and that's why they're not eating. And in the pelvic congestion syndrome world, I wish I would have known earlier on that there is, like, I don't want to say a cure, but there's really good treatment options for that. My clients who have had pelvic congestion syndrome and have gotten a stent, it's life-changing for them. Like, truly, I have 2 clients I can think of right now, no symptoms anymore, which is unreal. And I haven't seen that in many other surgeries. Always surgery should be last option, but there are certain things now that I see, okay, surgery might actually be a really, really good option here.
Cool. It's almost overwhelming.
It is.
How many different symptoms and types of hypermobility disorders there are. So let's try zooming out for a second, because I'm imagining that there may be people that listen to this, whether they're clinicians or people that think they may have a hypermobility disorder, and we just want to be better at spotting them.
Yes. Yeah.
So let's say that we have a person in front of us. Like, what are some sort of questions that we should start asking them if we're trying to determine if they have a hypermobility disorder versus something else?
Yeah. So for MSK clinicians, the biggest things that I want you to know and start doing is always screen for it. It is so quick. It is so easy. You can even just put it on your intake form. The 5PQ is a 5-question screen for hypermobility. You can go right on your intake form. And if that's positive, then do a deeper dive and you can go into the Bateman scale. That is a decent screening tool. It is not the end all be all. But if that is negative, that does not mean the person in front of you is not hypermobile. It only tests 9 joints in your system. We have way more than that. And again, you need 5 joints in your whole system to be hypermobile, to be categorized as generalized joint hypermobility.
Taylor, can we talk about the 5PQ first? What is that?
Yeah, so it's literally just a list of 5 questions that asks about, have you ever been able to touch your hands palm down to the floor? Have you ever been told you were double jointed? They're very, very simple questions, and it's actually testing for historical hypermobility, meaning were you ever hypermobile in your past? And so it's a good first screening tool to say, okay, if this is positive, I need to do some sort of hypermobility screening. And it's very easy. It's literally yes or no questions, takes 5 seconds.
Is it possible for people to have previously hypermobile joints and then that sort of excessive range of motion goes away, but you could still have a hypermobility disorder?
Absolutely, yes. So yes, and so historical hypermobility, meaning that you had a hypermobile joint and now it no longer is. If you had 5 or more of those, then yes, you could be in that category of generalized joint hypermobility. Usually though, that would be it kind of follows a pathway like anything else. Like, move it or lose it still works for hypermobility. And so what we really are seeing is that people get scared to move with this condition, whether that's because clinicians fear them away from it or they had a negative experience with movement. They stop using their range of motion, then they become stiff, and then that joint is no longer hypermobile as they're getting into old age. There is this narrative around that hypermobility follows a very strict, you're super bendy, and then you become stiff. that is not the case. The true reality is move it or lose it applies no matter what. And so it is not inevitable that you're going to be stiff just because you have this condition. If you learn to train properly and create control and create stability and create strength in your joints, you can stay bendy in a healthy way throughout life. I am a firm believer in that.
Cool.
I don't remember where we were.
So let's go back to the Baden scale for a second.
Okay.
What is it? And again, let's touch on why it's not a completely comprehensive tool for screening hypermobility.
Okay, so the Baden scale is a 9-point scale, and it's going to test your thumbs. It's going to test your pinky finger. It's going to test your low back, even though it's not actually testing low back hypermobility, but that's a soapbox for a different day. And it's going to test your knees and your elbows. As you can see, those are very limited amount of joints, and I don't know why 4 out of the 9 are in your hands. It's beyond me.
It seems so arbitrary now that you mention it.
Arbitrary. It's so arbitrary. But the reality is the Baden scale was never meant to diagnose hypermobility. It was I'm not going to pronounce this word correctly, an epidemiologic tool. Yeah. It was an epidemiologic tool. And then I don't even know why, but the EDS Society picked it up as the tool to put on the diagnostic checklist, which is why it is the most widely known tool for this now. There are so many other tools for diagnosing hypermobility, but I don't even think we have to make it a scale or anything. Like, just look at the person in front of you. If their end range is past what is normal, that joint is hypermobile. Like, I think we make this piece way too complicated, but the biggest issue with the Baden scale is that it doesn't test some of the most common joints like your hips and your shoulders and your neck and your jaw. Doesn't have any of those on there. And so people will go to a doctor or even a PT and they'll say, am I hypermobile? I'm having all these symptoms. I really resonate with this disorder. They get negative on the Baden scale and they're told, no, you're crazy. You're not hypermobile. Just because they do not pass the Baden scale does not mean they are not hypermobile. That's what I need you to know about this. And it is still a useful, good first screening tool. So if they do pass that, great, let's dive deeper. If they don't, but they're still coming in, resonating with this disorder and having symptoms presenting, let's dive deeper and maybe let's look at some other joints and see, do they go past their end range?
Yeah. Okay.
Yeah.
So I think as a physio, the area where we could probably come into play is help manage people's pain. Their MSK related pain with their joints. We can, as you mentioned, show them strength training and stuff. And I do want to get into that a little bit more with you. So let's talk about that. But at one point, I think we need to talk about all the other healthcare practitioners that will get involved in this process, because I can't imagine this long list of potential people that we might have to get involved.
Yeah,
so
absolutely.
When it comes to the pain that people experience in their joints, do you find that physio is a good treatment for people with hypermobility?
It depends on the physio. I'm a judge, the professional, not the profession. But I do believe that strength training and learning how to understand where your body is in space, so proprioception, and creating stability. And I do believe that there is also value in passive modalities like manual therapy, dry needling. These can be good additives, but they're never going to be a sole thing that's going to create long-term change. But so as a whole, the first line of treatment for this disorder is we need to get our muscles strong. And the reason for that is our ligaments are made of connective tissue and they become like an overstretched rubber band. And our body tries to help us out and say, I need to protect you. I need to keep you safe. So I'm going to make my muscles, which I have control over, really, really tight to create that stability for you. But if those muscles don't have the capacity to handle what they're being asked of, they're going to get fatigued. And then you're going to end up with potentially a subluxation in that area. And then that's going to lead to pain. Or we are going to find that when we are doing movement, we don't have the capacity to use our full end range, but we also don't realize or understand when we're using our full end range. And so then we end up in pain because of a capacity issue or a load management issue. And if we can work on learning, okay, body awareness. When am I in a hyperextended position? Not that it's always bad to be in that position, but we don't want to be in it all of the time. And we certainly don't want to load it past the point that it's capable of at this current moment. We have to build that up.
Got it.
And so what you'll hear from a lot of hypermobile patients is when I'm doing movement, I feel fine. There's no issues. But then after, I'm in debilitating pain. I can't walk for 3 days. I'm stuck in bed. My recovery is really slow. Those are the things that you'll hear from this population quite often.
Okay. So it's not necessarily that when people go to their end range that it's always a bad thing. But if they're sort of for like figuratively speaking, jumping into it. Like if you watch someone with hypermobility squat or do something, sometimes they just plop down into their end range really, really quickly and they don't have good control or strength in it. Then maybe that's a little bit more of an issue where they could get pain. But do you try and pull people back out of their end ranges and say like, hey, this is the proper range? Or do you try and give them strength in their end ranges?
Both. I would say both. So I like to meet people where they're at. And the first thing we always do is find where's our tolerable starting point with movement. And it also is going to be dependent on their goals. If they don't need to use their end range, meaning they're not playing a sport anymore, there's no reason for them they don't care about having a split, I'm not going to revolve their training program around let's make sure we use all of the range that we were given. I don't think that that's that valuable unless it's needed for your sport or for a hobby that you enjoy. Then yes, we're gonna strengthen that end range to the best of our ability. But if your goal is to be able to play with your kids and to be able to work again or to be able to walk again, that's probably not going to be on my list of priorities. That being said, one thing we're always going to do is make sure we are actually using our muscles and not cheating our movement with our end range. So that's another common thing that we'll see. And I'll use myself as an example for like box jumps. I will bring my legs all the way up and I'm not actually jumping that high. I just have the mobility to do it. And I'm not getting as much benefit from that movement because of it. And so that's a very common thing that we'll work on is, okay, we're cheating this movement. We're using our momentum. We're using our range of motion. I want you slowing down. And I want you to maybe even use an external cue at first so that we can know, okay, I'm going to stop at this point. I'm going to get that neural pathway formed. And then I'm going to take away the external cue and get really, really strong in that movement pattern.
Got it. I think a lot of people are going to have this question. When people have hypermobility and they're standing and they lock their knees out, oftentimes they get into this really funky position that it doesn't look normal for people without hypermobility. Like when people have excessive range of motion in their knees, it almost looks like that the knees could bend backwards a little bit, almost like a bird's leg.
Yeah.
And a lot of people say like, you should never stand like that. Other people are like, if it feels good, it's probably fine. Where do you stand on this?
It's the same answer as, literally same answer as I would say for posture. There is no good posture. There is no bad posture. We want to be able to get in and out of a hyperextended position. And what I care about is that you're in that hyperextended position. Because if you are standing in that position and you're unaware, you're going to stand in that position for too long. And that is going to create too much pressure in that area. Doing anything for too long is not going to be good for your system. And so we do teach intentionally, what does it feel like when we're in a hyperextended position? Do we know and are we aware how long we're staying in them? And are we changing positions long enough? But no, I do not think just standing in that position on its own is dangerous. If it was, I would probably be dead. Like my legs don't work anymore. And also like humans, we were born this way. A lot of us, most of us, we were standing like this our entire lives. And then we become an adult and we step into a chiropractor or a physio office and they tell us like, what you've been doing your whole life is going to kill you. Like that doesn't even logically make sense. So right. My opinion is there's a time and a place, and we want to make sure that we are able to get in and out of those positions, but no position is inherently bad within itself.
Fair enough. Yeah. Okay. Last question on exercise. I had Ben Cormack on recently, and the theme was about moving from biomechanics to biology. So
I love that.
sometimes when it comes to the bio and biopsychosocial, for some people, that just means biomechanical and not actually biology. We forget that all of our systems are sort of connected, right? And as we've spoken about with hypermobility, it's a systemic issue for a lot of people. It's not like it's just affecting one joint. As you said, your connective tissue is everywhere. And we even spoke about our immune system and how that likely plays a very, very strong role in a lot of people's presentations. And Ben is of the opinion that when people benefit from long-term exercise, when it comes to pain, it's not always because like you're fixing their mechanics or you're getting something stronger. Sometimes it's because you're actually maybe changing the immune profile of the body. Like chronic exercise can impact our immune system function. So is there a place for maybe just cardiovascular exercise for people with hypermobility and just overall improving the health of the person?
Absolutely, yes. And I'll answer your question first, and then I want to say something on that topic after. So I don't think we've talked enough about the autonomic nervous system, and that is a big, big component for this population. And so dysautonomia is when your autonomic nervous system is unhappy. It's a big umbrella term. There's 30 different types. POTS is the one you're going to hear about most, and POTS is going to affect your heart rate. It is going to usually make your heart rate a lot higher, especially when going from laying down to standing. And so cardio can be a lot harder for this population, which means that we have to just do it a little bit differently, but it still needs to get done. And there is a lot of protocols out there for POTS, like the Levine protocol, the Utah Adapt protocol. And I am not a fan of blindly following a protocol. And what I find is that people will follow those and get really upset that it didn't work and then blame themselves, when in reality, no protocol is going to work for every single person, and we need to adapt it and meet you where you're at first, because you might be starting at a much either harder or a much too easy starting point because you're just following what the protocol says. It doesn't know you. It just knows numbers. But yeah, so as far as we call it cardiac rehab in our program, but cardiac rehab is a big part of what we do. And the biggest difference is we're going to use our heart rate as our kind of guide, but not our rule book, to determine when we should push it or not push it, specifically when we are dealing with POTS. And those numbers are going to be very different than what you're going to find in the real world of like zone 2 training, et cetera, because somebody with POTS, their average resting heart rate is going to be on average 20 beats higher than somebody without it. And so we have to take that into consideration when we are working with this population. Because if you tell them, I want you to stay in this heart rate zone, and they're starting already higher than that heart rate zone, they're going to be really confused and really, really frustrated really, really quickly.
Right. Yeah, for sure. So a lot of autonomic nervous system issues with people. And POTS is postural orthostatic tachycardial syndrome, right?
Yeah.
So basically when people are like changing their postures, their heart rate can spike.
Yeah.
Which,
So when you're changing orthostatic hypotension, also very, very common in this population as well. It's also a form of dysautonomia. It just doesn't affect the heart in the same way, but the treatment is the same. Cardiac rehab, in my opinion, is the same for both of these conditions. And so when you go from lying down to standing up, your blood volume might pool down in your feet, and it might not get to your heart fast enough or your brain fast enough. And that's going to leave you with a racing heart, as well as brain fog, potentially fatigue, potentially dizziness. And it's going to make things like squats a little bit more challenging. And so we need to make sure that we're working up to it. And also something as simple as let's wear compression socks when we're working out and make sure that our fluid and we have enough salt in our system. That alone could be a game changer for people.
Wow. Okay. So a lot of things that we could do there from a movement professional basis.
A lot.
And again, I'm alluding to the fact that I want to talk about those other healthcare people as well. But before we do, just on that topic of exercise and the immune system and long-term changes, do we see that long-term cardio can help people with any of their systemic issues?
100%. 100%. And I would even say with POTS specifically, when you do a cardiac rehab program or an exercise program for at least 6 months, your resting heart rate changes. I see that all of the time.
Right. Even for a condition where your
Even for a
resting heart
condition.
rate is impacted.
Exactly. And that
Amazing.
is something that upsets me in this community is there's a narrative that you're kind of stuck and there's no hope and there's no changes that can be made positively. And that's just not true. Now, you may never go into remission. You may never be 100% symptom free. And I know that sucks and that's frustrating and we can grieve that. But that is not the same as saying we can't get better. Having no symptoms and having a really good quality of life are not the same thing.
Right. And I'm sure that's not just for POTS specifically,
Right.
but for hypermobility in general. I can imagine there's a lot of doom and gloom around it.
Yeah.
Okay. So when it comes to autonomic nervous system issues, is there room for other healthcare practitioners there? Like, are we getting cardiologists involved? Are we getting neurologists involved? What do we do there?
Yeah. So I'm going to just start at the beginning. So
Sure.
let's say you were told or you resonated with hypermobility in any way, shape, or form. Step one is what symptoms are affecting you most? Is it in the musculoskeletal family? Are we dealing with chronic pain? Are we dealing with subluxations and dislocations? If that's the case, PT or chiro or I don't like titles. So like anybody in the movement space that works with this population, that would be your first step. If you are more in the autonomic bucket of symptoms, meaning dizziness, brain fog, fatigue, blood pooling, heart rate beating really, really, really fast, really low blood pressure, anything in that family, we're always going to want to see a cardiologist first to rule out big, bad, and scary. And we always recommend anybody with a connective tissue disorder to get an echocardiogram because there are some risk factors for your heart just to rule out big, bad, and scary. And I make it very clear to my clients, the cardiologist might not know anything about your condition. That's okay. We just need them to run the tests and make sure there's nothing structural going on in our heart. That's really, really important. Once that's ruled out, the person who's going to be better fit for an autonomic nervous system disorder is a neurologist over a cardiologist. Unless the cardiologist specializes in dysautonomia, we find much more success with neurologists in this realm than we do with cardiologists. They're more so heart specific, and this is a nervous system disorder. It just affects the heart. So it makes sense why a neurologist would be more helpful. And a neurologist can be really helpful if conservative care and doing cardiac rehab and you have compression management, you have the nervous system regulation tactics, you have the salt intake, and you're still very, very symptomatic. There are certain medications that can be really, really helpful for this population. And that's when a neurologist can really be a game changer for people. And then the third is GI system is very, very commonly affected. And so I don't think I have a single client on my roster that I don't recommend a registered dietitian to. So having a registered dietitian on your care team when you're living with this condition can be really, really helpful. And the two that I recommend highly is Michelle Shapiro and Lily Long COVID Dietitian on Instagram. They are both great for this population. And then if we need also a deeper dive, seeing a GI specialist, especially if we're dealing with any sort of symptoms in the abdominal compression world, et cetera. And then lastly would be an allergist, especially if we're dealing with any sort of mast cell symptoms. An allergist can be probably the biggest game changer for this community because there are some certain mast cell stabilizers that are prescriptions like chromolim sodium and ketotifen that can drastically change people's lives, and you need an allergist to help you out in that realm. Those would be the four that I am most commonly recommending, but obviously every person is different. If you have something in the endometriosis world, we're going to want to see an OB. There's going to be other people we're going to always bring on. And then lastly, I recommend this to everybody, whether you're in the hypermobile family or not, having a mental health professional on your care team. The world is bleak. The world is scary right now. Have a therapist. Big fan.
Okay, good to know. The GI symptoms that people get, what else may that include?
Yeah. So most commonly, if you've been told you have like IBS or IBS-like symptoms, to me, that's a yellow flag of, oh, you might be dealing with some mast cell symptoms. And so up and down of diarrhea and constipation, or having pain after you eat, a loss of appetite, vomiting or nausea. Those would be the most common.
Okay. And anything with skin, like you mentioned allergists and the immune system, are there any skin related symptoms or
Yeah.
signs that people may see?
Yeah, so easy bruising is a really, really big one, but also easy bruising can be anemia. But
Yeah.
that is still a good one. If you're like translucent skin is one, so like if you can see your veins really, really easily, even when you're like tan, that would be something to consider and look into. And then in the mast cell world, being allergic to adhesives. So if you're patient and you put KT tape on them and their skin gets really aggravated, that would be a yellow flag. Having any sort of consistent hives, and then like if you were to scratch your skin and it stays red for a really long time, that would also be a yellow flag to look deeper and into. And then itchiness in general is a very, very common symptom that we hear. And then just being overall more sensitive to like products. So sensitive to normal skincare products or soaps or even cleaning products, that would be a yellow flag as well.
Got it. Okay. Again, there's so much here, but I feel like the purpose of this podcast was to really have this large bird's eye view of hypermobility, just so people could start being aware of this, how to spot it, and all the different signs and symptoms that can occur with it. And I think you did an excellent job at bringing most things up. Are there any like really, really big things that you think that we might have missed?
We didn't talk about upper cervical instability at all, which is one that usually comes up. So let's just speak to like the musculoskeletal world. Biggest things to know. One, if somebody comes in and they are coming in with a lot of systemic symptoms that don't seem to line up with what you normally see or hear, that should be a yellow flag. Let's ask some deeper questions about hypermobility. If they are coming in with an experience where exercise feels really, really hard or always hurting them and they are bendy, that would also be something to dive deeper into. Listen to the person in front of you. Do not just write off their symptoms and say, oh, that's anxiety, that's in your head, that can't be real, that's not a real thing. People don't really lie about their symptoms. I don't know why, as medical professionals, we think we know more than the person experiencing them. We don't. So listen to the person in front of you. And then there are some generalized rules as far as manual therapy goes for this population. The first would be no HVLA adjustments in the neck, specifically because
for the non-chiros.
So the big cracky ones, I'm not talking about the activator. I'm not talking about soft tissue work. I'm not talking about any of that. But the big cracky is a hard no for this population. Also, ask yourself, does the person in front of me need more range of motion? Because we know there's going to be a short-term increase in range of motion when we do manual therapy for the most part, especially adjustments. Does the person in front of you need that? Maybe they need a little bit less. So maybe that's not a good tool right now. But upper cervical instability is a condition that can come along in this population. And it is when first or second vertebra, too loosey-goosey. There's a lot of important structures in the neck, including your brainstem. They can move around, hit the brainstem, big, bad, and scary. We do not want that. You do not want to cause that in your patient because you decided to do an adjustment on somebody that is contraindicated. So be careful there.
People may get like vision symptoms, nausea, like a lot of things that don't sound normal for neck related pain.
Exactly. And with that as well, CSF leaks are much more common in this population. I was told in school you would never see a CSF leak in your entire career, and
cerebrospinal fluid.
Yeah.
Wow.
Yep. And I have seen far too many, like far too many, specifically after neck adjustments. And I'm not just shitting on chiros here. These are also done by PTs. I see it day in and day out, and we have to stop because it's not safe for this population. It's just not. And so if you don't know how to screen for this condition, that's a problem because you might be giving somebody something that can harm them. And so that's why screening needs to be number one, and then be aware of the risk factors. And also, we can get the same benefit from so many other passive modalities. We don't need to do a neck adjustment on, in my opinion, anybody, but especially this population.
Right.
And then Botox, if they are dealing with upper cervical instability. So Botox for jaw pain, Botox for even for migraines and for headaches is something we need to be really careful about in this population, because our muscles are the only thing providing us stability, and now we're numbing them.
Right.
That can lead to some...
You're paralyzing them.
And I have seen it cause some really big, bad, and scary neurological symptoms in patients with upper cervical instability. So you want to be careful with that. Same with dry needling. Even though it's more short term, we got to be careful. We don't want to just go in and release a muscle that is providing stability. Tightness is not good or bad. It is neutral, and sometimes it is there to protect us. We need to know when it is actually doing that, and we need to be careful with just going in and demonizing it and trying to make it go away. And then the nervous system and just overall higher sensitivity of this population, I think, is something PT should be aware of, especially with the products you're using. If you're doing manual therapy, let's make sure there's no scents in our lotions that we're using. Let's make sure our cleaning products don't have scents in them. We don't want our patient to feel unsafe or have a reaction because of something that is in our control. I'd say those are the big ones.
Amazing. I would love to do another podcast sometime talking a little bit more about treatment, because I think we spoke a lot about like spotting these things and some things that you could do, but I think we could go into a lot more detail on treatment. But I think this serves as a really good intro to hypermobility disorders for people. So Taylor, thank you so much. Where can people learn more from you?
And I would love to do another episode. Always down. I love talking about this stuff. So you can find me at the hypermobilechiro.com. I do have a clinician course that is 12 CEUs. It is asynchronous completely, and it will walk you through diagnosis, rehab process, and every flare in between for this population. So if any of this was like, I need to learn more, that's your place to go. And then you can find me on Instagram, the hypermobilechiro. Those are the two places. My DMs are always open. You can also email me, the hypermobilechiro@gmail.com. I'm truly an open book. I love talking about this stuff. So pick my brain any day, reach out. I'd be happy to help anybody.
Awesome. Taylor, thank you so much. It was great having you on. And we'll chat again in the future.
Sounds good.